Good evening all and welcome to today's CME, Koech Center of Kidney and Chronic Diseases. I see we are at 6:33 and should be ready to start. We'll give guys 2 minutes and start at exactly 6:35. Kindly have your mics muted if you're not speaking, and feel free to use the Q&A, the chat box to post any questions to the presenter. So it's 5 minutes past 6:30. I would like to again warmly welcome everyone for this evening's exciting continuous medical education session. I'll go straight ahead and introduce our speaker of the day. So our presenter today is known by many titles, and to some, he's an institute clinician, a physician nephrologist trained at the University of Nairobi, Moi University, and Stellenbosch. And his remarkable efforts to build a kidney transplant program in Eldoret have seen him featured in the Business Daily Top 40 Under 40. To others, he's a bold healthcare entrepreneur leading the Koech Center of Kidney and Chronic Diseases. And to many, he's a passionate teacher and mentor, dissecting complex renal concepts into easy to understand narratives. In his free time, he enjoys a good game of golf. However, today, he takes us through a testing of connective tissue diseases, a subset of illnesses that land at the nephrologist desk in one way or the other. So we look forward to a great session with insights and an animated discussion ahead. I introduce you to Dr. Mathew Koech. Over to you, Dr.
Yeah, good evening, Chris. I think in your spare time you should be a comedian. But thank you for the kind words. I hope I'm audible, Chris.
Yes, you are.
Okay. So good evening and welcome, everybody. We are going to quickly review ENA and ENA testing. Obviously, you realize that I'm a nephrologist and I might have a little bit of bias, seeing quite a bit of SLEs and needing some of these tests a bit more than the general people in the general setting. But we'll try and review the ENA testing. We'll talk about ANA and ENA. My slides are not moving. Yeah, we'll talk about ANA and ENA testing. We'll talk about why we test. We'll talk about the methods that are used in testing for ANA and ENA. and what the implications are for you as a clinician and for the patient as well. And then we'll talk briefly about what we do at Koech. I think part of the reason why this talk came up is we set up a lab, and we've been doing quite a bit of the ENA tests in Eldoret, and sometimes people ask questions about what the test means. So we'll talk about that, and then we'll conclude. I hope to do this session fairly quickly, and then and not delve too deeply into the science and the nuances of the tests, and then spend a bit more time at the end of it discussing and taking questions. And I think that's what will be more meaningful for most of you. So we will dive quickly into the deep end and talk about anti-nuclear antibodies. Anti-nuclear antibodies basically are antibodies that are directed towards certain components of the nucleus. I'm sorry about the typos. And they're often associated, their presence really usually denotes the presence of an autoimmune connective tissue disease. And we identify them by immunofluorescence. In fact, the gold standard for the screening of anti-nuclear antibodies is the use of indirect immunofluorescence using human epithelial cells, the HEP2 cells. Now, let's just recap that as much as we call them anti-nuclear antibodies, this name is not entirely accurate because some of the antigen targets of these antibodies are in the cytoplasm. But the name anti-nuclear antibody has been kept for historical purposes because originally it meant antigens in the nucleus. But some of the antigens lately have actually been identified in the cytoplasm. Now, how we test for these antibodies is we put a slide, and in the slide we put HEP2 cells, and then you take some droplets of diluted serum, okay? And normally people would start at a dilution of 1 in 100. Some people would start at a dilution of 1 in 80. Some people would start with a dilution of 1 in 40. And then you apply that on the HEP2 cells. And the thinking is that in that serum, there will be anti-nuclear antibodies which are going to bind to targets in those HEP2 cells. And once they bind and you wash, you will wash out the excess antibodies or antibodies that did not bind, but the ones which will have bound to the HEP2 cells will remain. And after that, now then you add a second antibody, which is anti-IgG antibodies with conjugated, or they are tagged with fluorescent, a fluorescing substance, which will produce light, usually green light. And then you wash the excess antibodies, and then you view the cells under a microscope, or you can actually use a computerized system to read the slides for you. And what usually you would see whenever there is the presence of anti-nuclear antibodies is you'd see patterns like this. If there is homogeneous staining of the nucleus, that's what we call homogeneous staining, like this one on the extreme left. If there is, sorry, let me just put up a pointer. If there is, so this is homogeneous staining here, there is speckled staining on that side, there is peripheral staining where there is staining just at the periphery of the nucleus, like that. You can get nucleolar staining, which is what this looks like. You can have staining around the centromere, which would look like this. And that positivity, the presence of light, is a positive ANA. And then the pattern is what you would see, like how does it look like? Does it look like any of this would be the pattern of the staining? And then, of course, you will mark the titer of antibody at which, the titer of the serum at which, or the dilution of the serum at which the positivity started from. And you keep diluting further and further and testing more and more until you no longer get positivity. At that point now, that would be the titer of the antibody. Okay, so at the molecular level or at the deeper level, what you'd really be doing is you'll have these HEP2 cells containing certain antigenic targets that you're looking for. And then when you apply the patient serum, that patient serum has antibodies directed against certain targets. And then you apply an anti-human IgG, which would bind to this anti-nuclear antibody from the patient's serum and light it up. And that's what you would be looking at the microscope. And again, on the microscope, these are real pictures of what you would expect. This is homogeneous staining once again. This is speckled staining. And this is the nuclear dot of kind of staining. And then you have the nucleolar staining where it seems like it's forming nucleoli like that. There's a nucleolus there, another nucleolus there, and another one here, and so forth and so forth. You'd have centromeric staining like this one in E. You'll have staining around the membranes. Like in this one, you'll see the intense lighting around the nuclear membranes. And then again, like we said, as much as they are anti-nuclear antibodies, some of the antibodies actually are in the cytoplasm. They would bind to antigens in the cytoplasm. They're still recognized as anti-nuclear antibodies. Now, the problem with this technique is it is time consuming, it depends on expertise, and it's subjective. And this really brings a lot of problems in terms of intra and inter-lab variability. So one lab technician will do it today, another lab technician will do it tomorrow, and you can get different results. And then between different labs, there'll be differences in results, and that brings problems. But it has advantages in that the HEP2 cells really have being cellular in nature and having native antigens like the other human cells. The number of antigenic targets are many, and therefore you can detect a larger number of autoantibodies as compared to what I'll talk about later. It has a high sensitivity. The sensitivity of ANA among patients who have SLE is up to 95–100%. And that staining pattern can help you generate clues to the diagnosis you're dealing with. And that's really what the advantage of anti-nuclear antibody staining or testing using immunofluorescence. But it has a low specificity, meaning there'll be a lot of false positives, especially the higher the dilution you use. So at a dilution of 1 in 40, the positivity, the specificity will be 43%. But it improves as you dilute more to 63% at 1 in 80. And we'll talk about some of these things. Different labs will use different cutoffs for their dilutions. There'll be labs which will do their dilutions up to 1 in 40. There are labs which will start their dilutions at 1 in 100. And that has implications for the specificity. The test can be affected by many variables, including the quality of the microscope bulb and the reader who is reading the slides. And remember that HEP2 cells, being human cells, they contain a lot of antigenic targets, but they do not have some of the targets that you might be interested in, like the Rho60 and the ribosomal P antigen. So you might miss some few targets because of that. And then it's labor and skill intensive, as we've said. So that really brings problems, and that might explain why some labs like Lancet and Metropolis, when you send your ENA test, it might take as much as a week, because this will have to be batched and they'll have to be run, and it takes time and effort. Now, positive ENA denotes the presence of a connective tissue disease, like we've said, and for the most part, really, we're usually looking for SLE and the mixed connective tissue disease. Once in a while, of course, things like rheumatoid arthritis can have positive ANAs. Systemic sclerosis is one of those big ones we tend to see. And the polymyositis, dermatomyositis, and the Sjogren syndrome, a bit rare, but those ones also will tend to light up with a positive ANA. SLE is the one which you will tend to see the higher rates of ANA positivity, close to 100. But the others, like the rheumatoid arthritis, the Sjogren syndrome, the positivity rate can be as low as 20 to 40%. So once ANA test is positive, what does it mean? So normally you want to look at the patterns to help you distinguish between the different antigenic targets and the disease entities. And then with the pattern and titer level, you can really improve your capability of distinguishing between those who are healthy and those who have a false positive. So the higher the titer at which you're getting a positive result, and the certain patterns will tend to tell you this is a more serious issue, yet other patterns really denote probably a false positive result. always be aware that up to 15% of the general population will have a positive ANA. So be cognizant of that. So it's therefore good practice to confirm the ANA by doing it properly using immunofluorescence, by looking at the patterns and by looking at the titer, and then do another second test, usually an ELISA test or an immunoassay of sort, like an immunoblot, to further specify the specificity or what targets antigens the ANA is against. Now, just be cautious that as much as we talk a lot about the patterns of immunofluorescence, the clinical relevance sometimes can be limited. So just be aware and look at this diagram here. Really, I think the short story behind this picture is most of the patterns that you will see do not necessarily give you a direction to where you're going. And for most of them, you will still need to do an extractable nuclear antigen or the ENA test to further specify and to narrow the disease process you're dealing with. The one pattern that tends to be very, very specific is the anticentromere pattern. So whenever you have an anticentromere pattern, that tends to really point to systemic sclerosis. And that's when you can go ahead and just test for the anti-CENP antibody. And usually that would tend to confirm your systemic sclerosis. But for the rest, really, you will still need to do an ENA because they do not necessarily point to any particular disease diagnosis. And I'll show you another diagram and another table which shows the complexity sometimes that these ENA tests can give you. Now, as much as we've said that the immunofluorescence is the gold standard and the best test you should do when testing for anti-nuclear antibodies, there are other tests that can be utilized, and immunoassays, which are based on solid phase assays, meaning that these are tests where antigens have been impregnated onto a piece of plastic, and then you apply the patient's serum, and then you test for the binding of these antibodies. I'll talk briefly about it. So the ones really that are currently largely used in the market are the ELISA and the line immunoassay. There are others as well, but this line immunoassay and ELISA are the biggest ones that you will see probably locally. And the principle of ELISA is as usual. So there are different forms of ELISA, but the basic ELISA is a direct ELISA where what you do is you impregnate an antigen on a piece of plastic, and the idea behind it is you put an antibody that has been tagged with an enzyme. And once the antibody binds to the antigen and you wash the plastic tray, the antibody will not be removed. And then once you add the substrate that is metabolized or broken down by the enzyme, you produce products that produces either light or color. And you can measure that light and color and quantify the reactivity to the anti-nuclear antibody that you're looking for. Most of the time, though, we'll be dealing with indirect ELISA, which is a bit similar. What will happen is you have antigens impregnated on plastic, and then you will put the patient's serum, which you expect to have anti-nuclear antibody. So the anti-nuclear antibody will bind to that antigen that you're suspecting. For example, it could be anti-Smith antigen. The antigen that anti-Smith antibody binds to, you've put it on the plastic. The anti-nuclear antibody against anti-Smith, which is basically the anti-Smith antibody, will bind. You wash it, but the anti-Smith antibody remains. And then you have an IgG antibody against human IgG that has an enzyme linked to it that will now metabolize a substrate that you will add later and generate light in a color reaction. And you can quantify that. So ELISA works like that, and some labs use ELISA for the quantification of ANA antibodies. But the one that really we've been using in our lab and is gaining popularity, at least locally, is the line immunoassay, which is based on the ELISA concept. Really, it's basically a piece of nylon test strip similar to the urine dipstick, but which has certain points impregnated with antigens. or antigenic targets. So like the one we have really usually has double-strand DNA targets, nucleosome targets, Smith D1 targets, SSA targets, SSB targets, and the SCL70 targets, and so forth and so forth. And the idea behind it is you impregnate this strip with the serum and you incubate. And the idea is that if in that serum there is antibodies against the various targets that you have there, the antibodies will bind, you will wash, and then if the antibodies are truly there, they will not be washed away. Then you will add a second antibody, which contains an antibody against human IgG, and that antibody is conjugated with enzyme or with some coloring agent that will change color. And once you add that antibody, there'll be a color change and there'll be a reaction that will change the color of the strip. And you can read the color of the strip as a positive or negative if you're doing it by eye, or you can use a machine to read the color change and to have certain cutoffs for positive and negative. And that's really what has been catching on, and that's what we've been using in our lab. The advantages of this kind of assay is they are very efficient. You can have a high throughput. You can test for many patients in a short period of time. You can test for many antigens in a short period of time. You can have simply quantification of the results, and you can automate, which further increases your efficiency and reduces your labor costs. So compared to the immunofluorescence, then you get these advantages. And you can, simultaneously identify the responsible antibody as compared to the immunofluorescence, where you're just seeing lighting up in the nucleus level, and you're seeing patterns, and you're deducing what kind of antibody you're dealing with. You can actually directly identify the antibody with this kind of testing system. It has disadvantages, though. It has a low sensitivity, so it's not very suitable for screening. Whereas immunofluorescence has a sensitivity of up to 95–100%. This one has sensitivity somewhere in the 70s to 90s, on average about 87%. So it's less sensitive as compared to the immunofluorescence. And these antigens that are impregnated in the nylon strip, you can only impregnate so many antigens. So compared to the HEP2 cells, which have all the human antigens that you expect anti-nuclear antibodies to bind to, in this strip you have only so many antigens that you can impregnate. So you'll miss out on some antigens. So if the patient that you're dealing with has a particular antigen that is not among those listed, then you'll be misled. And that explains the low sensitivity sometimes to this test. As you can see from literature, this is a research published showing the comparison or cross-tabulation between a positive immunofluorescence on the left and a positive ENA based on the immunoassays on the top part. And as you can see, the concurrence rate is there. There is some concurrence. As you can see, the positives for both are fairly many, and the negatives for both are fairly many, but there's this disagreement where it's positive on the one side, negative on the other, it's positive on this side and negative on the other. And really the total coincidence rate is generally in the 80s, about 86%. And for the positives, it's about 61% coincidence. And for the negatives, a little better at 95%. So this disagreement between immunofluorescence and the immunoassays is largely due to the disadvantages we've talked about, both the lack of a full repertoire of antigens, especially with the immunoassays, and then for the immunofluorescence, it has to do with the lack of specificity and the extremely high rate of the very high rate of false positivity that is observed. So, what is extractable nuclear antigen then, if ENA is already there? So ENA just looks specifically at the presence of antibodies against nuclear targets. And usually it does not specify, what antibody you're dealing with. You'll just see lighting up in the nucleus. It might be in a homogeneous pattern, it might be speckled, it might be nucleolar, it might be centromeric in type, but it doesn't specifically tell you what kind of antigen the antibodies are targeting against. So traditionally, people used to do salt extraction of nuclear antigens to try and identify what in particular the kind of antigen that these antibodies were against. And that explains why it's called extractable nuclear antigens. We no longer extract some of them. There are antibodies now that are extracted or identified in a different way without extraction, but the name has stuck and remains, as extractable nuclear antigens. And really, it is the specific antigenic targets that these ANAs are going for. Okay, so it helps to identify the specificity of that ANA and helps us firm up a diagnosis of a specific autoimmune connective tissue disease. For example, if you have a positive double strand after a positive ANA, then it helps you confirm or have more confidence in your diagnosis of SLE. If you have a positive ANA and you have a positive U1RNP as the ENA, then it helps you firm up a diagnosis of of a mixed connective tissue disease. And if you have a positive ANA with a positive SCL70, then it helps you firm up a diagnosis of systemic sclerosis. So that's what these ENAs do. But generally, you will need an ANA being positive. You'll need to look at the pattern. You'll need the titer. That helps you narrow what type of ENA you're going to test for. But it's not always that easy, though. So again, I think looking at the immunoassays, this would be one of the lists. This is the strip that we have in our lab. We have these antigenic targets as the ENAs, the double-strand DNA, the nucleosome targets, the histones, the SMD1, which is anti-Smith, the PCNA. Those ones are specific or indicative of the presence of SLE in the context of a positive ANA. The SSA or anti-Rho, there are two variants, the 60 kilodalton and the 52 kilodaltons. And then we have the SSB, which is the anti-La. When you have those ones, the anti-SSA and anti-SSB in the clinical context of a patient coming to you with joint pain, some fatigue, and some, enlargement of the parotids, maybe a dry mouth or dry eyes, then obviously then it's pointing more towards the Sjogren syndrome. And if a patient has features of scleroderma or CREST syndrome and has a positive ENA of the CENP type, which is the centromere type, or the SCL70, that helps you to point towards scleroderma or CREST syndrome. The U1RNP is for mixed connective tissue disease. The mitochondrial antibody M2 is for primary biliary cirrhosis. And then for the non-specific myositis, patients who come with features of myositis and you test the ANA, it's positive, you have specificity for anti-Jo1, anti-PM, anti-MI, and anti-KU, then that points more towards myositis. So that's what these ENAs help you with. And this is just a small list of the extractable nuclear antigens you can test for. There are a lot more, and there are more being identified. And as you can see, there are limitations to this kind of testing. So back in the day, obviously, the specific ENA testing used to be laborious because people were using immunodiffusion. But with the advent of ELISA, and especially with the recent use of multiplex assays means basically you are using ELISA type of technology, but you are impregnating several antigens on a strip or on a piece of microtiter plate. Then that helps to detect several antibodies at the same time and can actually be quantitative, especially if you use things like flow cytometry. But for the most part, it's usually qualitative when you're using the line blots or the line immunoassay like the one just shown. Okay, so the utility of ENA can be tricky. As you can see this table, it tries to help narrow in some cases, but in some cases it can confuse you a lot. In this table, I would like to point you towards this corner where we have the double-strand DNA, anti-Smith, anti-SSA, anti-histone, and those ones in the presence of a positive ANA, a homogeneous pattern, and the presence of these ENAs, that would really firm up your diagnosis of SLE. as you can see for the others, it can be all over the place. It can really be all over the place and might not be very useful. But when it comes to when you have an ENA positivity with a centromere kind of pattern, really it points to one thing. It points to the presence of this anti-C and P ENAs, which would be very consistent with a diagnosis of systemic sclerosis or an overlap syndrome sometimes. Okay. The other thing to note is that the presence of SSA antibody in patients with especially SLE is usually one of the things we look out for, especially in our nephrology practice. We look out for the presence of SSA when these patients are interested in getting pregnant, because SSA is associated with congenital heart block. So a patient who has a positive SSA would need a closer follow-up by a physician. Okay, so when should we test for ANA/ENA? It's a tough one really for physicians, because it's one of those things sometimes physicians get standards, but I think for the general physician population or the family physicians, I think people really need to be very careful when asking for ANA. The sensitivity, this is based on data from Canada, where they looked at the sensitivity and specificity of ANA testing in their population based on a general family physician practice. And they were seeing very low sensitivities and specificities, as low as 40% for sensitivity and 66% specificity. And people were doing a lot of tests. 94,000 tests were done in the year 2011, costing $2.2 million. And as you can see, despite doing 94,000 tests, for that year, there were only 259 SLE cases, and a total of about just over 300 cases of connective tissue disease. So I think we overtest a bit, especially in the general physician setting, and we really need to be careful about hazard testing for ANAs and especially ENAs. But for the physician, I think it might make sense in the right setting, and I'll talk about what the right setting is about in a short period of time. So again, remember, up to 15% of the general population will have a positive ANA, and the older they are, the higher the number of false positives, up to 40% among those who are over the age of 65. And I think the physicians in the meeting will confirm that of late, especially after COVID, we have been seeing a lot of positive ANAs. And that is testament to the fact that there is some transient positivity following a viral infection. So be careful about that. There are medications as well that can trigger ANA positivity, and there are malignancies that can trigger ANA positivity. Now, I would just like to take you back to the complex issue of statistics and something called Bayes' theorem. And really, Bayes' theorem says before doing a test, you normally, as a doctor, have a probability. There's a level of suspicion you have for connective tissue disease or for any particular disease for that matter. That pre-test probability is very important. And then the test you're going to order, its characteristics are also important. Its sensitivity and its specificity, and therefore what we call a positive likelihood ratio and a negative likelihood ratio would come into play. Now, I'll just give you a small example of when you use ANA for just screening in the community without, being screened by a physician. Now, in the community, the prevalence of SLE is about 0.1%. So let's mark it there. That will be our pre-test probability, because we're just doing a general community screening. Now, in a very good, a very good test like the immunofluorescence has a positive likelihood ratio of about somewhere between 2 and 5. So let's mark somewhere there. And then let's connect these 2 points. Sorry about my unsteadiness. And when you connect these 2 points, it's a bit not entirely accurate. But you can see that if you just test everyone in the community for ANA, because of the low prevalence of connective tissue disease in the community, or SLE for that matter in the community, and the performance of the immunofluorescence assay, really your post-test probability will just slightly improve to about 1 to 2%. So a positive ENA in the context of community screening is not very useful. I think that's what I would like to say. And then look at the second scenario where a nephrologist sees a patient, a young girl of 18 years old, has joint pains, has some malarash, has nephrotic syndrome, and really at that point, there's suspicion for connective tissue disease or SLE is probably 60 to 70%. I'm being conservative, it might be higher. And you're still using the same test, and you connect the 2 points, and you can see, voila, your post-test probability is very good. It's about 80 to 90%. And if you're really like 90% sure, like that patient, if was to come to me, I would be 90% sure it's SLE. When I test for NA, my post-test probability would be probably in the 90s. So the performance of the test and the prevalence of the disease in the community, or your pre-test probability, are very, very important. Now, the test is not very good in performance. So therefore, your clinical acumen is very important. You need to really take a history, think about all those manifestations of SLE, try and enumerate as much as possible before testing for your ENA, and that will improve your post-test probability. When the test comes positive, your chances of confirming SLE would be much higher, okay? Now, I will not talk about the negative likelihood ratio for now, and that's probably, I think because of time, we'll skip it. And just talk about some of the guidelines I found out there from Canada. And Canadians really generally do not indicate the use of ENA testing unless you have a significant clinical possibility of connective tissue disease. And they do not recommend that you use ENA tests to confirm a diagnosis of rheumatoid arthritis or osteoarthritis, and do not use ENA tests to evaluate patients with, non-specified fatigue, back pain, or some musculoskeletal pain, unless you have some other clinical findings like a malarash, like a renal insufficiency, or nephrotic syndrome, or hematuria, or cardiac symptoms. You need a lot more than just joint pains for you to test ENA, according to these Canadian guidelines. And they really do not recommend that you repeat ENA, especially if it's positive, okay? So the only time they recommend that you can repeat ENA is if it's negative and there's a strong suspicion that you're seeing an evolving connective tissue disease, then you can test. And actually, I have a patient like that who I'll talk about in a short while, was referred to me some while back from Kericho. So sometimes you have negative ENA. If truly you are convinced that the patient has a connective tissue disease, for example, for that patient came with a negative ENA, had nephrotic syndrome, was a young lady, and we couldn't get an explanation for this. So we had to repeat the ENA. And true to it, the ENA was positive, but I think it was 1 in 40. And we were a bit shaky. I'll explain that. I think that it's somewhere in the slide somewhere. But later on, the patient actually developed, I think after about a year or two, developed the full-blown symptoms of SLE. So sometimes you can see some evolving disease activity, and this is more for the physicians though. So repeating the ENA test is never wrong in such a scenario, but for the general physician population and for general practice, I think repeating ENA testing, especially when it's positive, is probably not advisable. So for ENA, really try and reserve it as a follow-up to a positive ENA. And in that case, you're helping to help you to specify the connective tissue disorder that you're dealing with. So for example, a positive ENA with a positive double strand will help you firm up a diagnosis of SLE. A positive ENA with a positive SCL70 will help you with firming up a diagnosis of scleroderma or systemic sclerosis, CREST syndrome, that kind of thing. And of course, a mixed connective tissue disorder would be confirmed to you by the presence of a positive ENA of the type U1 RNP. So it helps. And it helps localize organ involvement. For us who deal with SLE a lot, we use the double-strand DNA to help us. The double-strand DNA is usually a marker of bad organ involvement, especially renal involvement. Whenever there's a positive double-strand, most of the time we see renal involvement. That's how we use it ourselves. I don't know about the cardiologists. I think it's probably similar. I think double-strand DNA tends to point towards multi-organ involvement of SME. And then it helps with therapeutic considerations. You remember the story I talked about, the anti-Rho, anti-La, the SSA antibody. Whenever you have the SSA antibody in a young lady of reproductive age, those are the patients you want to advise that whenever they get pregnant, they really need to be under close monitoring and follow-up because of that chance of neonatal heart block. Okay, so I think in conclusion, really, ENA testing is pivotal to the diagnosis of connective tissue disease of the autoimmune type. There are challenges with the testing of ENA as we've looked at it above, and I've probably dwelt more on the technical side of things and talked about the utility briefly because it can be controversial, and I hope that we'll spend the remaining time just discussing some of these questions. The use of ENA or extractable nuclear antibody expands on a positive ENA test and will help you, localize the disease and to probably get some specificity to what disorder you're dealing with. So I would welcome our lab guy, Robert, to just tell us about the ENA test that we've been doing at Koech. We initially actually brought in this ENA test because we were seeing a lot of SLE, we were seeing a lot of positive ENAs, and we wanted to know what specificities of the ENAs we were seeing. The other thing for us in nephrology that we look at, and I'll show you a few examples here. I don't know whether this is clear, but this is one of our transplant patients that came in with renal failure and was on dialysis and had a diagnosis of SLE. So we did this before transplant and voila, it was so interesting. Everything was negative. So we wondered whether the diagnosis of SLE was pumped up. But looking at the file and looking at the history, she had flares of lupus, she had myocarditis, she had joint pains, she had all the features. So don't be surprised, sometimes some of these tests can be negative and it's just how medicine is. So for us, really, and I'll talk briefly about that, we look at how many antibodies are positive. The more antibodies are positive, the firmer your diagnosis, especially of SLE, but also the more antibodies you see, the worse the prognosis for the patient. And those are the patients who are likely to develop renal failure, heart failure, encephalitis and things like that. So those are the patients you really want to be aggressive with your treatment, the more antibodies you're seeing on your ENA screen. Now, this is just a sample of some of the tests from Lancet. And as you can see, Lancet, I don't know whether it's clear. It's not very clear. From Lancet, you will see an ENA positive, and you will see a titer. I think that's a titer of 1 in 640, and it's homogeneous pattern. So Lancet actually uses the immunofluorescence test and will give you the patterns. And then you have another one here. It's positive 1 in what, Robert? It's 1 in 40. Although that's a double strand DNA, which is 1 in 10. And then the patient has a positive titer of 1 in 5,120. I think this was one of patients who was referred to us here with very extensive discoid rash, had features of nephritic and nephrotic syndrome, but interestingly, the kidney function was preserved despite this very high titer. And then I think the pattern was also homogeneous. So this is Lancet reports. This is the Koech report again. As you can see, this patient has a lot of positives. This is one of our patients who has a positive ANA by latex and a lot of positive antigen specificities. She has extensive cutaneous disease, and she has nephrotic syndrome. But with treatment now, she's doing very well. And again, more of the Lancet types. This is the patient I talked about, referred to me by Dr. Muya from Kericho. Had been having nephrotic syndrome, a young lady. ENA had been done at Lancet a few months before, was negative. And we actually tested again. It was 1 in 80, I think, or 1 in 40, I'm not sure. But she did not have any symptoms of SLE. We put her on cyclosporine and she did very well. Then after a year, we were like, but we are not very sure about this diagnosis of SLE for you. You have a nephrotic syndrome, we'll put you on cyclosporine, let's taper off. We tapered off. And a few months after that, she came back with extensive cutaneous disease, very, very obvious lupus. So sometimes you miss patients like this. And then again, more of a ENA profile with a lot of positives. This is a patient who had lupus, was struggling with medications, and eventually went on dialysis. As you can see, a lot of positives. That's a bad prognosis. And then again, more positives. This is, I think this is an earlier test from MediHealth. Again, not very clear, I'm sorry. And then again, we also see men with SLE. So this is one of a gentleman with a titer of, I think, 1 in 500, I think 1 in 512 or something like that. But a negative double strand. He had nephrotic syndrome and positive ENA, but negative double strand, but doing very well on treatment for SLE. He had a speckled pattern, which is from Lancet, and and so forth and so forth. So I think I'll ask Robert to share quickly about the lab test we do for ENA, and then I think we need to spend more time taking questions and hearing from you, and we discuss some of these challenges that we're facing with the ENA testing. So thank you, and Robert.
Thank you so much, Dr. Koech. In 60 seconds, let me take you through what to do at Oak Tree Center. First of all, we do the ENA profile, which is the extractable nuclear antigen test with the 17 parameters. We don't do ANA. We started doing this ENA test in the year 2019. We've been sending our ANA samples to Metropolis and Lancet. It has been taking 5 to 7 days to do the test. And sometimes a week is so much for a doctor to review a patient. That's one of the reasons that made us to do the ENA profile. So this is our, what we use is the Imtech Analia Max, which is a kit from Human Chem Labs. It is an indirect membrane-based enzyme immunoassay, and it uses a nitrocellulose membrane. The testing procedure is simple. It takes around 2.5 hours to do the test, and we only need 1 ml of serum. And first, it starts with preparation of the sample, which is dilution of the sample. Then you prepare the nitrocellulose membrane by washing it. You do all this at 15 to 25 degrees Celsius, so probably room temperature. Then you incubate the diluted samples for 30 minutes. And after that, you wash 3 times. That is 5 minutes each wash. And then you distribute the conjugate. 30 minutes incubation, you also wash 3 times. After that, you incubate with a substrate for 10 minutes, and then you wash, and then you use a stop solution, which is sulfuric acid, for 5 minutes. Once you're done with that, you get, that is the membrane. These are how the results look like. As you can see, SSA, around 60 KD is very brown. You can compare it to the cutoff. So the nitrocellulose membrane as a reference line. And the kit comes with 24 membranes. 2 are used for controls, and then you're left with 22. So the reference line, the functional control, the cutoff control, and then you have the 17 parameters all lined up in the line, and you can cross-check the readings with the cutoff control. So maybe one of the challenges people face is qualitative testing is really dependent on the observer's decision, and sometimes equivocal results are a menace for the people reporting. This is an example of how we report the results at OCTRI. So additionally, we do the SLE latex test, which is specifically for SLE. And most times when the SLE latex test is positive, we have the first 4 turning positive. This is how we report our results if you send patients to OCTRI, this is what you see. Based on the insert of the human Analia Max kit, it has a relative sensitivity of 99.1%, but according to the research Dr. Koech shared, the sensitivity is around 87%. And then it has a specificity of 98%. And it's one of the reasons why we had to procure this test kit. So yeah, this is in brief what we do at OCTRI, and we thank all of you. Very soon we are going to procure a machine and do the ENA in-house so that we can help clinicians to make decisions quickly, so that we can know when to do ENA after the ENA, and it will be helpful to all of us. So thank you so much, and over to you, Dr. Koech.
Yeah, so I think we need to take questions, and I need to highlight the weaknesses of some of our testing strategy. I think initially we wanted to do ENA specifically, and the more we did them, the more people were asking us, but is the ENA positive then? And I think Kina Robert bowed down to pressure, and they started doing ENA, but they did the latex technique, which is a bit low in sensitivity. And that might explain why sometimes you have these positive ENAs, yet a negative latex, which doesn't make sense, but it's because of the nature of that test. We're thinking, going back to when people order the ENA, that we ask that they've done the ENA before, or we can actually do the ENA for them by immunofluorescence, which means sending to Lancet or sending to Metropolis for now. Maybe in future, we hope to invest in proper immunofluorescence in-house, but it's quite expensive and tedious. So we'll take questions, and I think we've seen a few. We'll ask Chris to take over from this point.
Yes, thank you very much, Dr. Koech. That was a great, really eye-opening discussion on testing for connective tissue diseases, all the way from the immunology to the clinical epidemiology and the real-world clinical relevance of the test. So just to start us off on the questions, I believe there was one by a gentleman and a lady, just named 1+. But the question is approach to management of a patient with a borderline positive ENA in -F. I'm not sure if that means they are a female patient. So that was the first one. And the second one, I would just bundle them. Dr. Billy Kurui asks, we have seen many patients who return PMSCL. I believe that's on the ENA test. What is the significance of this finding? To you, Dr. Koech.
Yeah, so I think the PMSCL, if I'm not wrong, is the scleroderma one. That's what, Robert? Yeah, SCL, no, SCL 70 and the C and PB would be the scleroderma type. The PMSCL is myositis. So, Billy, do you remember what the patient had? Did the patient have symptoms consistent with myositis?
I can't recall it because I think like there are several. I think another one had what I think the issues to do some I think some pericardial effusion and some joint issues. Yeah, but several I can't remember some. Well,
was there other symptoms? Yeah, so it's
Billy,
yeah,
hello.
it can be a bit difficult. So the PMSCL is what you would expect in myositis. If it's the only one, it can be a bit tricky. And personally, I want to believe that you need to see more positivities to get more convinced about a connective tissue disease. And Billy, had you done an ENA, or was the ENA just done by a lab using latex?
no, I think we just added we just asked it for the whole panel, and
Okay.
it returned like just the same that like the one you've just shown us here, but the only that was positive was that one of PM and SCL. I think Dr. Kanim wanted to say something.
Yes. Good evening, everybody. This is a
evening.
patient we had in our ward who had what looked like a nephrotic picture, what looked like a nephrotic syndrome picture, and we are screening for the possible causes. And once we send the patients for a connective tissue workup, it's the only result that came out positive, the PMSCL being positive, but the rest, including the SLE latex test, was negative, though we know the sensitivity is poor. But we're screening for the cause of nephrotic syndrome. Basically, didn't have any symptoms for myositis, muscle weakness, nothing.
Yeah. So in such a case, then I would be very hesitant to make a diagnosis of a connective tissue disease because remember, these tests have weaknesses. There'll be a fair amount of false positives. So the more positives you have, the firmer your diagnosis. And of course, you look at your pretest probability in the, based on your clinical acumen, the symptoms you're seeing before you do the test. So sorry to throw it back to you, but yeah, it depends on the clinical symptomatology and then the antibodies that you're seeing. We're going to fix it. I think we're going to be doing an ENA by immunofluorescence, and then we do the ENA for only those who are positive. And that will probably be a bit more meaningful for everyone. I think what we've been doing might have been misleading, and we're going to fix it. Now, I'm being told to remind you, put up your email address for CPD points. And then for those who have missed CPD points in the past, you can email the email address I've given you there, which is care@oaktreecenter.co.ke. If you email that address, you will be talking directly to the CPD coordinator and will help you with your CPD points issues. Is there any other question, Chris?
Yes, so thanks for that. So Dr. Menge Mora says that, looking at ENA down in Mashinani, or really anywhere in Kenya, I think there's the concern for cost. Yeah. And she says that, do you need to do ENA first before doing the ENA? And then have you had any false negative ENA patients who really the ENA test came back negative, but the ENA comes back positive, and then it helps you really narrowing down to your diagnosis?
Yeah. I'm trying to talk like a scientist, and I'm also trying to talk like a pragmatic physician. One of the reasons why we procured this kit is because we were really struggling with the cost of ENA. And you would send patients, they do ENA, they are paying how much, Robert? Is it 3,000, 4,000? 3,600 for the ENA test. And then after the ENA test comes, then you tell them, now you need to do what you call ENA now. And then they go to Lancet, and the ENA would be 3,000 something per antibody. So anti-double strand 3,000, anti-Smith 3,000, anti-RNP 3,000, anti-SSA 3,000, anti-SSA low molecular 3,000, anti-SSB 3,000, anti-Q, anti-what 3,000 each. And that would be a bit costly for patients. So we were very happy when we came across this kit that does a lot of antibodies at once. My sense has always been that if you really have a very strong suspicion for SLE or for some connective tissue disorder, including mixed connective tissue disease, scleroderma, Sjogren's syndrome, and interestingly, we've really diagnosed quite a bit of Sjogren's syndrome with this test kit. You know, these ladies who come with joint pains and swelling in their cheeks due to the parotitis. We've seen a lot of SSAs and SSBs being positive because of that. So a patient in the right context, I would really not fault anyone for going straight for this test, the ENA. And in such a context, then a positive ENA fitting the pattern of the patient's presentation would be taken as a positive ANA as well. So if a patient comes to me, has joint pains, has fatigue, has dry mouth, has parotid swelling, and we do the ENA and it's positive for SSA, high molecular, SSA, low molecular, SSB, and maybe Q or something like that, then I would say this is a patient with Sjogren's syndrome. If a patient comes, you know, fits the pattern of SLE, and I do the ENA and it's positive for double strand, positive for SSA, positive for SSB, positive for histone, positive for Smith, positive for PCNA, then I would say that's a patient with SLE. If a patient comes with, these are now Dr. Caronet's patients, patient comes with some unexplained hepatitis or some explained liver disease, is a female, and you do the test and the anti, you know, AMA M2, the anti-mitochondrial antibody M2 type is positive, and probably a few more are positive, then I would say this is a patient consistent with autoimmune hepatitis. So that's what we've been doing, at least in our practice, and probably I would encourage you to also use it in that way to save on costs. But the ideal textbook way, like I've said, from what I reviewed from the Canadian guidelines, is they recommend that you do an immunofluorescence ANA first. When it's positive, then you do an ENA to try and get your specificities. And yeah, Dr. Lagat, I agree with you. I was just saying what sometimes in the field you want to do, and then there's of course the theory. What do you think? I think we can ask Dr. Lagat to make a comment. Dr. Lagat, personally, if a patient comes, a young female, you know, comes with joint pains, comes with malar rash, nephrotic syndrome, and I'm thinking SLE, I think it makes sense to go for the ENA in such a case. What do you think?
Thanks, Dr. Koech, and we really appreciate the detailed basic science and clinical component to it. So that is a textbook patient where the clinicals are directing you towards a certain diagnosis. So every time you have a skin changes and you have the correct gender, the correct age, then you have some direction because you have a high clinical probability. But still, under those circumstances, traditionally we will do both ANA and then do an ENA profile. I think we will be taking a shortcut if we went to ENA and forgot the ANA. We do both. And if you remember, Koech, before we had the chance to do a long profile, we still used to do both an ANA and the double-stranded DNS. And we used to do ANA first, and then we go to the double-stranded DNS. But now with a kit like the one which is available in Oaktree, we'll do the ANA and then do the ENA profile, because it gives you other other components to patient care. If, for example, as you mentioned before, they have high and persistent and DNA and the DMS and the RO and the SSA, then that is somebody who, if they become pregnant later, we know they have a small chance. It's not high chance, it's like 2% of their offspring getting congenital heart block, because these antibodies cross the placenta. And in terms of cardiovascular disease risk, and you did mention that, then the risk of atherosclerosis and having a lipid panel that is unusually progressive and atherogenic is high. So I would do ENA and the ENA panel because it makes economic sense. You don't save much by skipping the ENA. I would ask for both ENA and ENA. The challenge you get in clinical practice are circumstances where you have difficulties building a pretest probability. And a good case in question is somebody who presents with uncharacterized tiny pericardial effusion or pleural effusion. And you'll hear people in the ward say, a screen for connective tissue disease. But which disease? You know, that is the challenge where I live. And thanks again for the chance to comment.
Thanks, Dr. Lagat. Dr. Lagat is a cardiologist and of course, a very seasoned physician in this Eldoret town. And we work very closely. And I'm sure all of us struggle. Billy and Kinaganim, I'm sure you all of us struggle about some of these things. So I think to help Menge, I think it would still be the right thing to do an ENA by immunofluorescence, and then when it's positive, we do the ENA. So we will try and look at our protocol at our lab to accommodate that, so that the patient can pay for ENA and ENA, and then if the ENA is negative, we consider putting a discount or something. I don't know how it will be done. But for the other places, I don't know what, I think they will engage with Lancet and Metropolis and see whether they can come up with some form of package that can help physicians. Whenever a positive ENA comes, then they can follow it up quickly with an ENA without asking the patient to go back and pay more. I think that would be the discussion that would probably help most of us. Unfortunately, for some of these private labs, the ENA, they will charge for antibody, and that makes it a bit challenging for the patient and even for the physician to choose which antibodies to ask for. Okay, Chris.
Yes, thank you. Thank you for that. I think that's very good to dive into some cardiology perspective. So Dr. Korir basically was asking, that Daisy Korir, the first question was similar, whether to do an ANA before, which I think has been well answered. Just to add is that she asks, what's the significance of a positive U1 RNP or KU with symptoms, but the ANA, you are not able to do an ANA? And I believe you've partly answered that, but you can just touch on it briefly, as also you answered Dr. Pauline Ogola. And she asks, what's the utility of the ANA test in patients with other autoimmune disorders other than systemic illnesses? So things like autoimmune immunobullous, SLE, and cutaneous lupus. You can handle those two first.
So a positive U1 RNP is the probably one of the common ones we see at our lab, and it's consistent with what many of you would probably see most of the time. It's these patients who come with a variant of connective tissue disease that you can't really pinpoint. So they have joint pains, they have fatigue, they have some bit of rash here and there, but not really fitting any particular biclinical phenotype, that is not really fitting SLE, not really fitting scleroderma, not really fitting any of the phenotypes of connective tissue disease, not fitting SLE fully, not fitting scleroderma fully, not fitting rheumatoid arthritis fully. And those are the patients, when you get a positive U1 RNP, it really confirms your suspicion of a mixed connective tissue disease. So that's what the U1 RNP goes for. The other question, Chris?
So the other question is utility of ENA test, and possibly, if I may add, ENA, in patients with illnesses, cutaneous autoimmune disorders, such as cutaneous lupus and bullous SLE.
Yeah.
Yes.
Yeah. I think my little knowledge of SLE says that most of the cutaneous forms of SLE do not really have systemic involvement, and you therefore rarely get a lot of positivity for these antibodies. Most of these antibodies become positive the more organs get involved. So your double strand, usually for us, a double strand really tells you the kidney is in danger and the brain is in danger. The more you get, the SSAs, the PCNA, the Smiths, and all that, the more those antibodies light up, the worse the prognosis is for the patient, and tells us that we need to be aggressive. So those are the patients you'll see as being very, very aggressive. The cutaneous forms, I would expect them to have very little antibody positivity, including even ENA itself might be negative. The double strand definitely is likely to be negative as well. They might have the SSAs being positive, but little else otherwise. So I'm not a skin specialist. I'll not say what to do, but that's what my sense would be. I don't know whether Dr. Kiprono is on the call or anyone in dermatology. Yeah, Chris.
Yes. So yeah, I'm also not sure, but I think that really sums it in a way that we can take home, and definitely it's something to continue pondering about and continue asking ourselves questions. Maybe I can go to the next question. And Dr. Njuguna is concerned that sometimes a patient can come with undiagnosed SLE, as you've said. These illnesses do evolve. And because of the continuous inflammation, more tissue damage exposes more antigens, and therefore more antibodies come about. And so do you handle that as a mixed connective tissue because almost everything on the ENA is positive? Or you go back and say, okay, what started this was SLE, and let us treat as SLE. I'm not sure if there's a difference really in treatment, but you can comment on that.
Yeah, so there's, and I like that he mentioned something that I put it close to my heart, the epitope spreading. So the more the SLE becomes untreated, the more the autoimmune process exposes cryptic antigens, and therefore the more the autoantibodies that develop. So a patient who has a lot of positive antibodies on the ENA tells you that that patient has had untreated SLE for long, and the disease has really hit a lot of organs and exposed a lot of cryptic antigens. Those patients have generally a poor prognosis, so you need to really get on top of the disease and control it aggressively. So that's how I normally look at it myself. So I wouldn't call it a mixed connective tissue disease. I would call it SLE that really has become progressive and advanced.
Okay. Yeah, so we should just stick to the initial illness and possibly discuss prognosis, but also treat aggressively. And I think more importantly, refer to the concerned specialist early. So Dr. Maleche had a 22-year-old male with immune-active hepatitis B and extrahepatic manifestation of nephrotic syndrome and panserocytis. For this concern that there could be something just more than the hepatitis B causing these symptoms, and asked for an ENA panel, which showed anti-PM SCL positive, which we had discussed, you had shared is really for pushing us towards scleroderma. How would you interpret that? Would you take it as a false positive? Or
No, I think I made a mistake. The SCL70 is scleroderma. The PM SCL is for myositis. So if the PM SCL was the only positive, I would probably not take it seriously and consider that it's just a false positive. And probably the patient is just suffering from hepatitis B. If there was a bit more, like the double strand, the UNRNP, the anti-Smith, anti-histone, then I would probably think about SLE. But if that was the only positive, I would probably safely consider it mostly viral and not being an autoimmune connective tissue disorder.
Okay. Thank you very much. And Dr. Cheriot Robert brings in a testimony just to build up on what you just talked about a short while ago. So he's a middle-aged lady with diabetic hypertensive and had some B symptoms with panserocytis and interstitial lung disease and history of Raynaud's. And recently started on anti-TBs, I believe, due to the interstitial lung disease and the B symptoms.
Yeah.
And an anti-U1RNP came back positive. And for that, they started the patient on management for mixed connective tissue disease. And possibly you can comment on that and just to help highlight the concept you just shared.
Yeah, I think they were right on the money. The patient seems to have autoimmune connective tissue disease, not necessarily pointing in any convincing direction, seems to have panserocytis that might go for lupus, has interstitial lung disease that would go for lupus, that would go for systemic sclerosis, some Raynaud's as well, which would go for both. And when they did the ENA panel, it was U1RNP. So that would be consistent with a mixed connective tissue disease. And what I normally do myself, I don't know whether Beryl is on the call, is I would treat according to which one is the most striking disorder. Most of the time for me, it tends to want to look more like lupus, and I would treat it more towards lupus. And that's how I would do. Sometimes we have these patients who have what we call overlap syndromes. A good example is what we call lupus, which is features of rheumatoid arthritis and features of lupus, with a positive ENA, a positive rheumatoid factor, positive double strand or positive histones and Smith, and things like that. So those are patients also you would want to treat based on which one is the predominant disorder. I think the last time I saw a patient like that, about a few weeks ago, she had a very predominant rheumatoid arthritis picture. So we treated more towards that direction. And that would probably mean at some point we might put her on things like tocilizumab, which is a monoclonal antibody against rheumatoid arthritis. If the patient presents more in keeping with SLE and has these overlaps, we normally treat more as SLE, and in terms of monoclonal antibody, we would tend to want to use rituximab more. Yeah, so that's how we normally look at it, and it can be very complicated sometimes and very tricky. Yeah.
Thank you, Dr. Koech, for expanding on that. And so I see we are 8 minutes to 8 and time is gone, but then there was one final question by Robert asking what is the role of ENA testing in Raynaud phenomenon and how you'd interpret it, and possibly take it back as well. Yeah, so maybe you can have that question before we move on to our closing remarks.
Yeah, so again, I think we need to emphasize what we said earlier, that your pretest probability is very important. You need to have a high pretest probability. So if the patient has Raynaud's only and nothing else, and nothing to go for lupus, nothing to go for systemic sclerosis, I would probably be very cautious about over testing the patient. I would probably do an ANA first. If it's negative, that will be it for me. But if an ANA is positive, then I'll again do the ENA as we've discussed. And being Raynaud's, you would be expecting probably SLE phenotype or a systemic sclerosis phenotype, and therefore you will be looking out for the specific antibody profiles for each. So if it's more of a dsDNA, anti-Smith, anti-histone, anti-PCNA, SSA, SSB type, that would be more in keeping with lupus. And if it's more of the anti-SCL70, anti-CEMP type, then probably it's scleroderma. If it's the UNRNP, as we've said, that will be a mixed connective as well. The beauty is the treatment is largely, the treatment of these connective tissue diseases is usually fairly similar. You wouldn't really make a lot of mistakes. So sometimes we talk about trying to identify the particular one. Sometimes you can't. And as long as you have your clinical background in terms of your pretest probability solid, and you've backed up with these tests, I think then you can embark on starting immunosuppressive medications.
Asante, Doc. That is very, very clear. Context is everything, and looking at other symptoms as well, and the patient's picture in general. So I see Dr. Billy Kuru's hand is up. Dr. Billy?
Oh yeah, okay. I just remembered that case that I was trying to say earlier. So this was a young lady, 21 years old. She was from Kitale, and we were rotating in dermatology clinic. So she was being treated for scabies, but the presentation was not like the scabies I've ever seen in my life. She had these lesions that it's like rashes all over. They were marked more at the buttocks, but all the way around the perineum and to the anterior chest and at the back, and she was itching and paining a lot. So after she had been seen, I followed her and told her to wait a little. I wanted to talk with Dr. Kibrono about her. So I called Dr. Brono. I told Dr. Brono, I think this thing is more than scabies. I think there is something else. So Dr. Brono came, we saw. Then he said, let us order this this panel from Octrian, and we see. So that's when it returned the PMSCL positive, and the others were negative.
Yeah.
So later, I don't know how they found their way to Nairobi. So later she called me and told me that they have seen somebody, I think, in Nairobi hospital, a certain professor who ordered more tests, and I think I've sent you in your WhatsApp the results. So this one, they ordered the extractable nuclear antibodies that showed SSA and IRO, which was positive.
SSB,
yes, and Lao. I think you have seen it.
SSA and SSB, yeah.
Yes.
So that would be, and was that the only one positive? That would be in fitting with a Sjogren syndrome. If the patient has the right symptoms, but could also be SLE. SLE can light up those SSA, SSBs, but usually when SLE does that, you expect one of the other ones to be positive, the Smith or the PCNA or the histone or the double strand. Did she have any of that?
No, it's only those two only. And surprisingly, she didn't have all the other symptoms of Sjogren that we know. Mucous membranes were okay.
Yeah. Yeah. So that's some of the challenges sometimes. Yeah.
So,
Yeah, anyway,
yeah.
Chris, I see a few hands which are raised. We can finish with them and then we release everybody. We're almost out of time.
Yes. I see Dr. Lagat. Dr. Lagat's hand is up. Over to you, Dr. Lagat.
Yes, just a quick one, Dr. Koech. One, the cutaneous SLA thing, I think they do both systemic. I'm pretending to be Kiprono here, but they also do biopsy of the lesion, and between those they should make a diagnosis. My comment number two, and then a question is, I think to everybody we should keep trying to build a clinical impression and a pretest probability. We really should try that. Sometimes we are at a loss, but we should keep trying that. For the case of the patient started on anti-TBs, we have a lot of molecular techniques now available for confirming TB. We need as much as possible to stay away from putting patients with connective tissue disease and lung involvement of anti-TBs on empiric purpose on empiric grounds without going far enough in confirming the presence of TB, because rifampicin really messes up your pharmacology with all the other drugs. And then lastly, Dr. Koech, a question to you. I didn't hear anything about what COVID and COVID vaccine status does to these tests. Does it change it at all?
I think you might have missed it, Dr. Lagat. One of the triggers for a positive ENA is a post-viral state. Okay. And I'm sure, Dr. Lagat, you've seen as much as also as we've seen a lot of positive ENAs in, especially the elderly, 50s, 60s, patients who have been treated for COVID a few months or so before. So I think that's usually just post-viral and needs to be taken as that.
I saw a 59-year-old today with rheumatoid arthritis, diagnosed late last year after COVID vaccine, and is on some serious stuff, and is on treatment in Aga Khan. And it had my head. I don't know. I'm still thinking. I might end up discussing with you.
So without the proper pretest probability, those are things that will happen.
59.
We all need to be cautious.
Thanks.
I think, Chris, thank you very much. I think it's been great. We don't want to keep people too long. Thank you. I think we had a record attendance today for Humble Oak Tree. I think we had 100 plus at some point, although our limit is 100. So I think thank you everyone for coming. I'm really happy. I hope we've been of value to you. We've added value to your lives, to your clinical practice. And we hope to see you again next week. Over to you, Chris.
Thank you very much, Dr. Koech. As promised, it was an animated discussion, very insightful and quite enlightening. And the audience are really thankful for you coming in, giving us a very engaging session that has allowed us to learn quite a lot. To the team that's behind the scenes, making sure that the session is organized and sending out the invites, the CPD coordinator, are thankful as well. Just as a closing, so we really thank you for your attendance, and we look forward to seeing you again in 2 weeks. I'll just ask Robert to share on the chat any details of how a physician who's been, has been scratching their head, getting a patient with a very high pretest probability somewhere in Kisumu, somewhere in Kisii, somewhere in Kakamega, and they want to do an ENA test rather than going through the expensive testing, how they can send their samples and how they can reach Oak Tree. So other than that, thank you very much and have a good night.